Dr. Maria Pamela Pahati, she finished medicine at the University of Santo Tomas. She had her urology training at East Avenue Medical Center and became a diplomat last 2018. She pursued her 2-year fellowship for pediatric urology at Philippine Children's Medical Center.
Good afternoon. I am Maria Pamela Pahati, and I'm here to discuss on managing pediatric urinary tract infections. So these are my references for today's lecture. And these are the objectives. We'll discuss the prevalence of pediatric urinary tract infection, the risk factors for developing UTI in this pediatric population, how to diagnose, to treat, and to monitor patients with UTI. Urinary tract infection in children is the most common bacterial infection in children. About 20% of pediatric patients consult because of fever. And amongst this pediatric population with fever, UTI is responsible for 7% of those patients. Incidence of UTI varies depending on age and sex. So here, this table shows that the incidence for boys with UTI is highest during the first 6 months of life and decreases as they age, as compared with the female, where UTIs are less common during the first 6 months of life but increases with age. So why are we concerned of children having UTI? It is because of your renal scarring. And we know that renal scarring can lead to long-term sequelae of hypertension and renal deterioration. So there was a study done by Swerkenson, noting what happened to patients or do they develop renal scarring or renal damage after UTI. Here, it showed that a lot or most of the children with febrile UTI actually do not develop renal damage. Only 1/5 or 20 out of 100 children will eventually develop renal damage. And these children who progress to renal damage are those children with recurrent febrile UTIs, especially those in combination with high-grade VUR. And we see that the risk of renal scarring increases with the number of febrile UTI the patient has. Here, when the patient had only one febrile UTI, you see that the risk of renal scarring is just 3%. And it increases to 30% after 3 or more febrile UTIs. So our goal in these pediatric patients is really to prevent renal scarring. And it is our goal to identify who among these children are at risk for recurrent febrile UTI. And in doing so, we have to really have a high index of suspicions for UTI in the pediatric population, especially in infants and children less than 2 years old. No, the evaluation should include history and the importance of physical examination in pediatric patients cannot be overstated. So when we do our physical examination, these are the questions that we have to ask our patients. Is it the first time or is it a secondary infection? Are there possible malformations of the urinary tract? Does the patient underwent any surgery, about a family history, or whether there is constipation or presence of lower urinary tract symptoms? So when you see pediatric patients, they're not really like the adult patients, especially in infants and neonates. This age group is quite challenging when we make the diagnosis for UTI, because symptoms in infants and neonates are very vague and very non-specific. Symptoms such as poor appetite, failure to thrive, lethargy, irritability, vomiting, and diarrhea can also represent other diseases apart from UTI. Toilet-trained children are they are more able to describe their symptoms and localize them to the urinary tract, such as they can complain if they have flank pain or suprapubic pain. Of course, physical examination is very important to do in pediatric population. And this includes examination of the abdominal area where you have to palpate whether there is tenderness, there's palpable mass. For the back and the spine, you see for external lesions such as dimpling, lipoma, hair tuft, or vascular malformation. For the genitalia, for boys, you have to inspect the urethral meatus. If there's phimosis, you'd want to observe urinary stream for these patients. For those female patients, you'd want to check if whether these patients with UTI has labial adhesions. And of course, you have to get the general physical examination of the patient, their body weight and their temperatures. So before administering any antibiotics for this patient, urine sample must be performed. So there are 4 methods of urine collections, and each collection, the more invasive the urine collection is, the less is the possible contamination. So when do we recommend or when do we advise proper urine collection? So for plastic bag attached to the genitalia, we know that this is the least reliable because contamination rate is very high, about 50 to 60%. It is only helpful when the culture results are negative, or when the result of this plastic bag specimen is negative. Then that's the only time that it is helpful. Otherwise, it is very non-reliable. For clean catch urine collection, it showed good correlation of urine culture between collection with clean catch urine and between your suprapubic aspiration. It is recommended and can be done in older children, older girl, or in circumcised boys. The contamination, though, is higher, about 26% compared with catheterization of just 10% and SPA of 1%. Your transurethral bladder catheterization is the fastest and the safest method. According to the AAP 2011, it is recommended collection for young non-toilet trained children younger than 2 years of age. Although its disadvantage is it's being invasive. And of course, the most invasive, but the most sensitive method to obtain an uncontaminated urine sample is your suprapubic bladder aspiration. We can also do a dipstick and microscopy for urinalysis sample. So your leukocyte esterate is a surrogate marker for pyuria. Your nitrite is your specific for detecting bacteriuria. So your nitrate will be converted to your nitrite by most gram-negative enteric bacteria in the urine. So the use of this dipstick is that if the dipstick leukocyte and nitrites are both positive, then there is high positive predictive value for UTI. However, if it is both negative, there is high negative predictive value for UTI. So for microscopy, this is the standard method of assessing pyuria. So in the centrifuge urine, abnormal is more than 5 WBC per high power field. And it is very important to know, and it is essential for the diagnosis of UTI is a positive urine culture. So how do we diagnose urinary tract infection? The urine is considered sterile. So if you're going to collect a suprapubic aspiration for your urine specimen, recovery of any organism is considered as urinary tract infection. For catheterized specimen, according to the American Association of Pediatrics, 2011, the recovery of at least 50,000 colony-forming unit per ml is diagnosed of urinary tract infection. And if you're going to catch clean catch method for urine specimen, recovery of more than 100,000 colony-forming unit per ml is diagnosis of urinary tract infection. So now we know how to diagnose urinary tract infection. Now let's go to the risk factors. Who are the children that has higher risk factors for developing recurrent febrile urinary tract infection? So as what I said in the few earlier slides, the only time that UTI are more prevalent in boys than in girls is at age younger than 1 year old. So we see here that 2.7 boys versus 0.7 girls will have UTI in the first year of life. UTI occurs in all races, but they appear more commonly in the Caucasian girls as compared with the other races. How about circumcision and UTI? Circumcision reduces the rate of UTI development in the first 6 months of life by almost 10-fold. This is because it is during the first 6 months of life where there is an increased amount of uropathogenic bacteria colonizing the prepuce. And this colonization appears to decrease and resolve by 5 years of age. So can we recommend doing circumcision for all newborn kids? So there was a meta-analysis done by Singh Grewal where they identify that for normal healthy boys, they only have 0.5 to 1% risk of developing UTI. And you see that the recurrence rates increase to 10% in patients with recurrent UTI and increase even more to 30% in patients with high-grade VUR. So in this study, they calculated that approximately 111 has to undergo circumcision in order to prevent 1 UTI in normal boys. And the needed number to treat decreases to 11 in recurrent UTIs patients. And we need only 4 circumcision to be able to prevent 1 UTI in high-grade VUR. So again, in patients with high-grade VUR and with recurrent UTI, it is more recommended to do early circumcision as compared with normal boys. And according to the AAP Task Force on Circumcision 2012, now, although health benefits are not great enough to recommend routine circumcision for all male newborns, the benefit of circumcision are sufficient to justify access to this procedure for families choosing it. And what are these benefits? The specific benefits identified included prevention of UTI, penile cancer, and transmission of some STIs. Okay. So other population in the pediatric population that are at high risk for recurrent UTI are those patients with neurogenic bladder. So the neurogenic detrusor sphincter dysfunction, your NDSD, can develop as a result of a lesion at any level of your nervous system. And this condition contributes to various forms of your LUTD, which can lead to UTIs, VUR, and eventually to renal scarring. So a lot of patients with neurogenic bladder have normal upper tracts when they were born. But unfortunately, up to 60% will develop upper tract deterioration due to bladder changes, UTI, and or VUR if not treated properly. So identification and prompt management for these patients is very important. So the goal of treatment for patients with neurogenic bladder are to, of course, prevent urinary tract infection, prevent upper urinary tract deterioration, We want to achieve continence at an appropriate age. We'd want to promote good quality of life as possible. So starting these children, the patients with neurogenic bladder, on early intermittent catheterization greatly decreases the chance for renal complication and the need for later augmentation. So this is how we manage patients with neurogenic bladder. We start with intermittent catheterization with an antimuscarinic medication. After that, these are the more invasive management for those patients. And for those patients on CIC, a lot of them will have bacteriuria and or pyuria and are mostly asymptomatic. So 40 to 80% on CIC. Do we need antibiotic for these patients? According to Ottolini et al. 1995, in patients without VUR, asymptomatic bacteria on CIC does not pose significant risk factor for renal damage, and thus they do not require antibiotic therapy. So how do we do CIC? Do we have to do it sterile versus non-sterile? Can we use the tube single time, or can we use it multiple times? Can we use lubricated or non-lubricated? So comparing catheters used in CIC showed no difference in reducing the risk in developing UTI. Another risk factor for pediatric patients in developing UTI is your vesicoureteral reflux. So your vesicoureteral reflux represents the retrograde flow of urine from the bladder to the upper urinary tract. So we have the primary reflux and the secondary reflux. Your primary reflux, the main reason is that there is a fundamental deficiency in the function of your UVJ anti-reflux mechanism. For your secondary reflux, your UVJ is overwhelmed by problems other than deficiency in your UVJ. So this is your international reflux grading system, grading your vesicoureteral reflux into grades 1 to 5. So here, initially, they divided it into 1, 2, 3 as your low grade VUR, and your 4 and 5 into high grade VUR. But now a lot of studies are made, and they now classify VURs into non-dilating VUR, which is your grades 1 and 2 VUR, and your dilating VUR, which are your 3, 4, and 5. Because your dilating VURs are the VURs that are at higher risk of developing acute pyelonephritis and renal scarring. So what is the importance of VUR and UTI? Your VUR per se is not a cause of your UTI, but the presence of VUR with UTI facilitates pyelonephritis. So it facilitates going of your bacteria from your bladder going to your kidney. And so if you can see here, not all of the patients who had history of acute pyelonephritis will eventually have scarring. It is only 1/3, or about 37% of children with history of acute pyelonephritis that will have renal scarring. And it has been shown that presence of your vesicoureteral reflux is a risk factor for renal scarring. And we don't want renal scarring for the reason that it can lead into long-term sequelae of eventually renal deterioration, renal insufficiency, and hypertension. So when do we perform VCUG? We know that VCUG is your diagnostic of choice for your vesicoureteral reflux. According to the AAP guidelines, no, for 2 to 24 months with febrile UTI, they recommend doing voiding cystourethrogram after the second febrile UTI, and or if there is an abnormal finding in the renal bladder ultrasound. So once you have abnormality in once you have the reflux, no, we want to know as to whether this patient already developed renal scarring. So the gold standard for identifying renal scars due to infection is your DMSA, or your dimercaptosuccinic acid renal scan. But this detects irreversible renal damage, and this is done 6 months post presumed pyelonephritis. So you see that abnormal DMSA scans are more often seen with dilating VUR, and the likelihood of spontaneous resolution of VUR is less likely with an abnormal DMSA. Important to mention is another approach. So earlier we've discussed, in order to diagnose your VUR, your vesicoureteral reflux, we go first for the VCUG, which is your bladder. And if the patient has reflux, that's the time we do our DMSA to detect renal scarring. For the top-down approach, initial DMSA scan is requested first, and if it is normal, then no need to do your voiding cystourethrogram. However, if scarring is found on your DMSA scan, then VCUG is recommended. So in patients with normal DMSA with no VCUG, yes, we will fail to identify 5 to 27% of VUR. Although this VUR are said to be less significant. And in contrast, if when we do the top-down approach, this would avoid unnecessary VCUGs in more than 50% of those that were screened with DMSA first. So we know that your vesicoureteral reflux has a tendency to resolve spontaneously, depending on the grade, depending on the age of the patient. So most of the patients with low grade, grades 1 and grade 2, will have resolution as high as 80 to 90%, and about 30 to 50% in patients with vesicoureteral reflux of grades 3 and 5 within the 4 to 5 years of age. That's why during this observation, or during while waiting for it to resolve, we can offer your antibiotics, your observation, or your surgery. And if with indication, we do the surgery. So what is the medical management of patients with vesicoureteral reflux? So you see here that, so your CAP is your continuous antibiotic prophylaxis. So you see here that it is clear that antibiotic prophylaxis may not be needed in all patients with reflux. Because trials show that benefit of your CAP, or your continuous antibiotic prophylaxis, is none or minimal in patients with low-grade reflux. So when do we recommend giving your continuous antibiotic prophylaxis? So the continuous antibiotic prophylaxis is useful in patients with grade 3 and 4 refluxes to prevent recurrent infection, but its use in preventing further renal damage is not proven. So for toilet-trained children, children with recurrent UTI, with PBDs, with renal cortical abnormalities, these are the patients that would benefit from CAP. So this would decrease UTI in 50% of the time, but not the renal scarring and its consequences. For boys, toilet trained, even with high grades of VUR. But if the patient doesn't have BBB or recurrent febrile UTI or abnormality in your renal scan, then your CAP can be optional. So important for children with VUR of more than 1 year old. Um, Recommendation, if the patient has BBB or bladder bowel dysfunction, you treat the BBB first, before doing any surgical intervention. So these are the choices for your antibiotic prophylaxis, your trimethoprim sulfamethoxazole, your nitrofurantoin, and your first generation cephalosporin. So these are the dosages, and when you will not give, at what age these medications are not recommended to give. And when you have breakthrough infections, you have presence of scarring, multiple episodes of pyelonephritis, when you have persistent high grades, your grade 4 and grade 5, if you have intolerance of medical therapy, then surgical treatment of your vesicoureteral reflux is recommended. Another risk factor that can cause recurrent UTI in children is your bladder bowel dysfunction. So your bladder bowel dysfunction is also very common in children, but most of them are unlikely or are likely underdiagnosed in the pediatric population. So what happens here is that you have an increase in your fecal load that can affect the bladder emptying and storage. So in two ways. First is that because of mechanical compression, so it compresses the bladder and hence decreasing the bladder capacity. And this decrease in bladder capacity and this decrease in bladder capacity can cause urge incontinence and frequency. Another is that because of the increase in the rectal fluid, there is change in the physiologic neural stimuli of the bladder as well as the pelvic floor. And this could lead to progressively increase in the or decrease the urge in evacuation, or can cause chronic bladder spasm, insufficient emptying, and significant post-void residual. So relieving the child's issues, correcting the constipation of this patient can reduce urinary tract infection. So summary of the diagnostic tools in patients with pediatric urinary tract infection. So your renal bladder ultrasound are non-invasive, relatively inexpensive, and safe in any age group. And it is the most common modality used to evaluate anatomic abnormalities such as duplication, dilatation, and obstruction in the genitourinary tract system. For young children with a first UTI, RBUS is unlikely to alter clinical management, and it is not universally recommended. So your AAP guidelines, as well as your AAP guidelines recommend renal bladder ultrasound for children 24 months of age after their first febrile UTI. For NICE guidelines for febrile UTI, they recommend, it is age dependent, they recommend doing your renal bladder ultrasound after the first febrile UTI in children less than 6 months of age or older than 6 months for those with atypical or recurrent UTI. Your voiding cystourethrogram is the modality to evaluate for your vesicoureteral reflux. Your AAP guideline recommend doing it after the second febrile UTI or if an abnormality is seen in your renal bladder ultrasound. Now, for the NICE criteria, again, it is age dependent. Now, for less than 6 months, if with recurrent UTI or atypical UTI. If for 6 months to 3 years old, if with history of vesicoureteral reflux, for those with non-E. coli UTI, for those children with poor urine flow and hydronephrosis, But it is not recommended. It is not routinely recommended for children more than 3 years of age. How about the recommendation for your dimercaptosuccinic acid? So your DMSA can provide information about the extent of renal inflammation and renal scarring. Children with acute DMSA changes are at risk for VURs grade 3 to 5 on VCUG. However, both the NICE and the AAP guidelines do not recommend using your DMSA in routine evaluation of children with first febrile UTI. So your AAP do not include the use of DMSA in their recommendation. Your NICE guidelines for febrile UTI, they only recommend DMSA 4 to 6 months after in patients with atypical or recurrent infection in children less than 3 years of age, and those with recurrent infection in children more than 3 years of age. So how do we manage patients or pediatric patients with urinary tract infection? So the choice between oral and parenteral therapy should be based on the age of the patient, the clinical suspicion of urosepsis, illness severity, refusal of fluids, food and oral medications, if the patient has been vomiting, diarrhea, or if they're non-compliant, and those with complicated UTI. But parenteral therapy is greatly favored over oral medications in newborn patients and infants aged less than 2 months, because in this population, there is an increased risk of urosepsis and severe pyelonephritis. So how do we choose the antibiotic for this patient? We base it on the local antimicrobial sensitivity patterns. And it should be adjusted according to the sensitivity testing of the isolated uropathogens. The choice of antibiotics should be guided by good antibiotic stewardship. And it is very important that we know the local resistance pattern, because it can vary between countries and more so even between hospitals. The duration of treatment is 7 to 14 days. So for the antibiotic, so not all available antibiotics are approved by the national health authorities, especially in infancies. So before the cultures are available, these are the choice of treatment for the patient. So for those patients needing IV medications, and if this patient has normal kidney function, tobramycin and gentamicin is started. However, for those children with abnormal kidney function, alternatives are your ceftriaxone and cefotaxime. In children who can receive oral treatment without any known resistance to urinary culture, your cefixime or your amoxicillin clavulanic can be used as an empiric treatment options. Important to note also that we really have to treat your febrile UTI promptly, because any delay in the treatment in children with febrile UTI for more than 48 to 72 hours increases the risk of renal scars. Okay, so these are the antibiotics and when we can use it, and when it is not recommended to use. So for neonates and young infants, since these children has more, they for neonates and young infants, they should be covered for Enterococcus species. And since Enterococcus is sensitive to ampicillin and first generation cephalosporin, these antibiotics are added to this group population. Your nitrofurantoin should not be used for febrile UTI or pyelonephritis because of poor tissue penetration. Your nitrofurantoin is associated with increased risk of hemolytic anemia in infants less than 6 months of age and in patients with G6PD. Your trimethoprim sulfamethoxazole is not recommended for less than 6 weeks of age, no, because your sulfas, because of the liver prematurity, your sulfas may increase your risk of current icterus in young infants by displacing the bilirubin from the plasma protein. Fluoroquinolones can, although your fluoroquinolones should not be your first line choice, and it can only be used in patients with suspected or proven resistant uropathogens such as your Pseudomonas aeruginosa. So how do we monitor UTI in patients? So with successful treatment, your urine usually becomes sterile after 24 hours. Leukocyturia normally disappears in 3 to 4 days, and normalization of body temperature can be expected within 24 to 48 hours after the start of therapy. However, if you notice prolonged fever and failing recovery, then repeat ultrasound examinations is recommended in these cases. So for recurrent UTI, recurrent UTIs are again problematic, no? Because symptoms are bothersome to children, and recurrent febrile UTI will also result in renal scarring. Therefore, it is important to prevent the incidence of recurrent UTI. And chemoprophylaxis is commonly used to prevent UTIs in children. No, however, we also have to weigh resistance versus benefit of giving chemoprophylaxis to the children. So who will benefit from chemoprophylaxis? Those are children with anatomic abnormalities of the urinary tract system, children with BBD and VUR, and the specific group of patients with incomplete bladder emptying with properly performed clean intermittent catheterization, but still suffering from recurrent UTI. So in conclusion, we know that UTI in pediatric population is very common. In fact, it is the cause of, it is responsible for 7% of febrile episodes in 20% of children being worked up for fever. We have to get good history and physical examination, as well as knowing the different risk factors to aid in diagnosing children suspected of having urinary tract infection, and accurate diagnosis and prompt management of pediatric UTI is a must. Thank you.